group C and D, the ones that had the adjuvant, the 50 micrograms of the adjuvant, which is a plant-based adjuvant, and received 2 doses, were the 2 most immunogenic vaccines. And we can see here, we have the placebo, A, B, and you can see the 5 microgram and the 25 micrograms, a double dose, those 1 and 2, using the matrix, which is the matrix MI is the adjuvant. They had the higher, and this is the anti-spike IgG, the highest level of antibody, and they actually use convalescent plasma levels to compare. These are patients who actually recovered from COVID. Some had asymptomatic disease, some were hospitalized, like the one in purple, and other had like just outpatient COVID. And you can see that the level of antibodies with the vaccines were actually comparable, or maybe slightly higher, but definitely similar to convalescent plasma on those 5 micrograms and 25 microgram double dose of the vaccine. So probably they're going to move forward with the 5 microgram because, as you can see, produces the same immunologic response. These are the neutralizing antibodies, which is the other measure that we have shown in previous studies. Again, decent levels of neutralizing antibodies comparable to the convalescent plasma in the double dose adjuvant vaccine. So good results from the humoral immunity, and there was a correlation between the anti-spike, because this is basically a spike protein injected, between the anti-spike IgG and the neutralizing antibodies. A linear correlation, very clear, on the generation of neutralizing antibodies associated with antibodies to this spike protein. Looking at the T cell response, from the best 2 candidates, the 5 microgram and 25, both generated Th1 type of cytokines and cellular response, and almost none Th2, which is considered not appropriate. When you use this type of vaccine for respiratory viruses, you prefer Th1 because Th2 had been associated with some evidence of lung inflammation, especially with the RSV vaccine. So this protein with adjuvant produced good humoral response and good cellular response. And that was basically the conclusion of this small study, phase 1/2, and they're obviously going to move forward with this protein vaccine to the phase 3 studies. The other clinical trial that was published was the Gamaleya Institute vaccine, or the Russian vaccine, as it is known on the media. This is actually an adenovirus, human adenovirus, recombinant adenovirus vaccine, and uses 2 different adenovirus 26 and adenovirus 5. And within that adenovirus, which is actually a virus that can cause a reaction in the body, but it's not replicative. The inside of this virus, they put a small piece of genetic material that actually produces the spike protein. So the idea is to use this as a vector to get into the cells, and then to produce the protein, and then the immune system will recognize the spike protein from the coronavirus, and thus give you protection. They actually, I'll show you the design of the study. They actually did 2 studies, one with a frozen vaccine, they call it a Gamaleya COVID-Vac, which is basically frozen, and another one, lyophilized preparation, 38 volunteers in each arm, so a relatively small phase 1/2 study. And they actually administer different preparation. There's no placebo here. To one group of 9 subjects, they gave just the adenovirus 26. Another group just got the adenovirus 5, and then 20 receive sort of a sequential, the adenovirus 26 on day 0, and then adenovirus 5 on day 21. So it was sort of a prime booster with 2 different adenovirus. And the idea is that in case the subject has immunity to adenovirus 26, natural immunity from previous infection, you're given the protein, the S protein, with a different adenovirus the second time around, with the hope of producing a better response. And very similar for the lyophilized vaccine 26, 5 by itself, or the combination, which is what they actually plan to do on the large. And then they follow this patient and evaluated the immune response, safety, and immunogenicity. And by the way, I didn't mention the safety of the Novavax vaccine, but they obviously did not detected any serious adverse event in those small study, just local and systemic reaction, but were not really considered serious. And this is the results of the Russian study regarding antibodies against the spike protein, or the RBD, which is the receptor binding domain, the specific part of the spike protein that is presumed to be associated with neutralizing antibodies. And you can see that for the combination on day 28 and 42, there were significantly high levels of antibodies, both in the frozen and the LIO formulation. And again, they use also a very similar idea. They compare with convalescent plasma from Russian patients that had recovered from COVID-19. So these are the levels of antibodies, which you can see that are similar to the levels achieved in day 28 and 42 with this vaccine. So apparent good immune response. The same with neutralizing antibodies. You can see the levels at day 42, pretty decent levels, very similar to what you get with the natural infection, according to these Russian scientists. And when you look at T-cell immunity, they actually measure the proportion of CD4 and CD8 cells that were stimulated or growth, and they found basically also good cellular immune response with these adenovirus, recombinant adenovirus vector vaccine, and also interferon gamma release also, which is a sign of Th1, again with the two formulations of vaccine. They didn't find any significant difference between the two preparations, the frozen and the other, the lyophilized vaccine. So their conclusion was that this heterologous adenovirus vaccine with 26 and 5 had a good safety profile and induced strong humoral and cellular immune responses. After the study was published, I saw in the social media some criticism to some of the graph and values. They said that some of the values were repetitive, so they're questioning the result. But obviously, we have to wait for the authors to respond to those criticism in the journal. But at least they published the phase 1/2 study. Another different issue is the use of corticosteroids. You remember we actually talk about this with the recovery trial. The recovery trial was a UK large trial that demonstrated that steroids, especially in patients requiring oxygen or in mechanical ventilation, had a mortality benefit or decrease in the mortality from using dexamethasone. So the investigator from the WHO group, called the WHO Rapid Evidence Appraisal for COVID Therapy, actually did a meta-analysis of the 7 randomized clinical trials that have been published using steroids. They actually put together all those 7 trials, a total of 1,700, approximately 1,700 critically ill patients with COVID-19, and their conclusion was that they actually found in this meta-analysis was that in those 1,700 patients, there was an odds ratio of 0.66 of mortality, so a 33% less mortality when they were treated with corticosteroids. And in this case, they used not only dexamethasone, but they included methylprednisolone and hydrocortisone in their different trials. So it's sort of another piece of evidence that actually it's additional to the recovery trial that was published before, giving usefulness for steroids to decrease mortality, but especially in patients with severe COVID or advanced COVID, not at the beginning of the disease. That's important to clarify. And then we move, just to finish, a couple of interesting transmission papers or papers on transmission, both from China. And the first one, it's an outbreak. It's really, really interesting. This is an outbreak that occurred in China during the lockdown. And it occurred in a 30-story floor residential building in Guangzhou City. In that building, there were 202 residents, 57 families. Some of the flats or apartments were unoccupied in that relatively large building. And actually, they documented 3 families in that building affected. The index family, or the first one, had traveled to Wuhan, and then they found cases on the 25th and 27th floor. And the interesting thing is that this is the sort of the blueprint of the building, and there were like 3 areas: the area 01, 03, and 04, and all of the cases in the 15th, 25th, and 27th floor occur on these areas. So the authors actually postulated that those infected in the 15th floor somehow transmitted the disease through the pipes, to the black water pipes in the building. And they actually have a drawing and their hypothesis, and you know, it's a sort of exploratory hypothesis that because the virus is excreted in fecal matter, probably when the families living on the 15th floor that were infected actually send the virus into the pipes essentially, and then fecal aerosols probably travel up the black water pipe and got into the bathtub or floor drain in those bathroom in the 25th and 27th floor, because there was no other epidemiological exposure for these families except for being in their house during the pandemic, and no contact with the family on 1502. So that's and they did also, they actually tested also a gas. They put like a marker gas into the system, and they were able to document the presence of the gas in other floors, especially if the U trap that it was dry. There was no water here. You can get the vapor of the gas to come out of the drain. So interesting. And these have been seen before with the SARS-CoV-1. Some of you may remember the outbreak in the Amoy Gardens building I think in Hong Kong with the SARS-CoV-1. There were several people in that building affected with SARS-CoV-1. So I thought it was interesting. The other outbreak, it's a demonstration of another outbreak in a closed environment. This was an activity that also happened in China, in which there were a group of lay Buddhist who were going to a religious event. One group went in a bus, 60, and another one 68, another bus, and there was one person infected in bus number 2, and actually 24 out of the 68 turned out to be positive later on. So there was a 35.3 attack rate just by sharing the bus for 100 minutes. It was an air conditioning bus, so it had a closed ventilation system. And this is the sort of the pink and yellow are people who became infected. White are those who did not become infected. This is actually the drawing of the bus, and you can see that all over the bus there were positive persons with COVID, and the index patient was the one in red here, identified by IP. This group also shares some time in the actually temple that they visited, but the attack rate in the temple was much less. It was only 4.1% of the 172 people who attended that religious activity. Only 7 that were not in the bus got infected, as opposed to 24 out of 68, illustrating the potential for transmission in a closed environment like this with air condition for 100 minutes. So that was basically the conclusion. All right, thank you. So I want to stop sharing, and we'll go to the questions.
Thank you so much, Nestor. Marla Sievers has a brief update, and then Leslie Hayes has a brief update, and then we'll go through the questions if okay, Nestor. Marla?
Thanks, Joanna. I just had a brief announcement. Department of Health is engaged across many divisions in planning for SARS-CoV vaccine rollout, which we are told may be expected as soon as sometime in early November. And so all state health departments are currently engaged in planning for receipt of this vaccine and rollout. CDC has set some priority groups for vaccine, one being frontline healthcare workers and the other being residents and employees in nursing homes and other long-term care facilities. And as part of our vaccine planning, we will be sending out a survey through the statewide immunization registry at the end of this week, asking all healthcare providers, primarily acute care hospitals, community health centers, FQHCs, to respond and provide us some information about frontline healthcare workers in your facility, particularly those that are engaged in high-risk activities like ICU care or respiratory therapy, and also some questions about your ability to store vaccine and how many vaccine providers you might have at your location. So what we're currently planning for is a rollout to priority populations as early as late fall and through the winter, and then scaled up rollout, which may reach population levels as early as this spring. And so we're trying to plan for how vaccine will be deployed around the state using partners like pharmacies, hospitals, and FQHCs to help us do that. So if you receive that survey, please respond. We're using it for our planning for vaccine rollout. And once that goes out, I'll bring the link to this meeting next week in case you're unsure if your facility has received that, and I'll bring it so that you all can follow up if you'd like for your facility to make sure that someone received that survey and responded. Thank you.
Thank you, Marla. Do you know which vaccine is being entertained for the state?
All we've been told now is that, among the 6 sort of primary vaccine candidates, there's 3 that we hear a lot about, and they are anticipating that at least one, we've not been told which one yet, is available for early distribution sometime in November. And like I said, CDC is going to set some priorities with HHS about who that vaccine will be available to first. And then the anticipation is that that will continue to scale up through the winter, and that by spring 2021, we may have enough vaccine available to make it widely distributed through the population. So more to come. There's a lot of, we have more unanswered questions than answered at this point, but logistically, we're starting to get ready for that rollout.
Thank you, Marla. And please chat in your questions. I want to turn it over to Leslie Hayes, who has a brief update as well.
I was mostly going to focus on mental health and COVID today. First is just depression, and they had a telephone survey of 1,441 adults that they compared with NHANES data from prior to COVID-19. And not surprising, they found that depression was much, much higher. It's about 3 times higher. It's especially high if you have lower income, less than $5,000 in savings, and quite high if you've had exposure to more stressors. They also found that people who were married have less risk of depression than people who are widowed, divorced, or separated, or people who have never been married. So I think it's really important we be screening patients for this and offering referral to treatment. And I think it's also, in my experience, been helpful just to kind of normalize it. I have patients calling in and saying, I don't know why I'm not coping, and talking to them about the fact that this is actually very, very common and multiple people are suffering from depression at this point, I find has been reassuring to them. There was also a New York Times article about this where they were talking about the long haulers. Actually, anxiety and depression has been a very common symptom for them. Anxiety was actually the 8th most common symptom they listed. Then difficulty concentrating and depression were also common. And part of the reason they gave was that people didn't take them seriously, thought they were just kind of milking it, or didn't really have this, or being unreasonable about it. And so normalizing it and saying, yes, that this can happen afterwards really seemed to help. And then some people actually stated that participation in online support groups improved their mental health symptoms. And then we've mentioned this before. Wall Street Journal had a pretty good article this last week about the opioid crisis and just rising drug fatalities across the country. They surveyed US adults in June, and 13% they had either started or increased their substance use to deal with stress or emotions related to COVID-19. Social distancing is making it a lot harder for people to access meetings and counseling. And then the pandemic also interrupted the supply chain. So as a result, people often needed to go to new dealers, and potential for more potent drugs or potential to be contaminated with fentanyl, any number of issues. And then people are still, this is still an issue of people delaying or avoiding medical care. In June, there was an estimate that 41% of US adults had either delayed or avoided medical care, including emergency or urgent care and routine care as well. And I think it's really important we do let people know it is safe to come into our clinics. The studies have really shown that people are not getting COVID from healthcare settings at this point. I think the medical system, despite not getting great support on PPE, I think we've done a wonderful job of doing everything we can to make sure it's safe in our facilities. And I think it's important to let people know that. And especially if you look, the people who are not getting urgent or emergency care was really prevalent among people who are also at high risk for COVID. So unpaid caregivers for adults, persons with underlying medical conditions, Black adults, Hispanic adults, young adults are the only group not at high risk, but persons with disabilities. And then this last one I thought was cool. So when I was 8, I actually read an article about how they developed the smallpox vaccine. And I thought that was so cool that I decided I wanted to be a doctor. And almost 50 years later, here I am. And so, so this was an editorial in the New England Journal, and it was about variolation. So the difference between variolation and vaccination is that variolation actually uses the actual virus, and it induces a mild infection, and you get immunity from this. And there was a really wonderful book a few years ago called The Speckled Monster that talked a lot about a noble lady in England and a doctor in colonial America who introduced variolation into their communities. And variola is the scientific name for the smallpox virus. And so you're using just a small amount of smallpox virus. They would inject just a small amount and induce immunity that way so that people didn't get bad infection. Vaccination is where you're using something that's not actual virus to induce immunity. And that's the original vaccine was vaccinia or cowpox. So, and what they found was universal masking seems to reduce the rate of new infections and possibly increases the proportion of infections that are symptomatic. And they think it's due to the variolation, that when you get exposed to it, you get exposed to a much smaller amount because the masks are filtering it out. So, and they had a few examples of this. There was an outbreak on a closed Argentinian cruise ship where the passengers were provided with surgical masks and the staff had N95. The rate of asymptomatic infection on that ship was 81%. And there was an earlier cruise ship where they did not have masking, and that was only 20%. There were also 2 recent outbreaks in US food processing plants, and all the workers were issued masks, and there were asymptomatic infections among the 95% of the infections were asymptomatic among more than 500 people, and only 5% actually had symptoms. And then in countries that had mandatory enforced population-wide masking, the case fatality rates are lower, even when you have resurgence of cases. So I just thought that was kind of a cool thing and a good reason to wear masks. So, and that was all I had.
Thank you so much, Leslie. Thanks for all the great updates. I'm going to turn it over to Carla, who's going to start with all the great questions.
Yeah, thank you, Joanna. Yeah, there's a lot of questions, so we're going to try to combine some of them, I think. So Nestor, just the two studies that you presented at the end, the one about particularly about the apartment building. There are a couple of questions. Like I'm just going to go over a few of them, and you can talk about that. They were asking about how did they know basically that it wasn't in the air and then transmitted through the air? And also one of the questions was, didn't people use the same elevators? Like how did they decide that was the way that was transmitted?
Yeah, well, first of all, there were no other cases in any other areas of the building. So that was one. It was only on that tower, on that part of the tower. Second, they interviewed all of the affected families, and according to what they reported, they didn't coincide in any social areas or elevators, as far as they could remember. So they basically did it because they rule out other ways of contact. And as I said, there were no other infections in any other areas and on the same floor, or people who actually share the elevators more. So that's how they concluded. Obviously, this is a working hypothesis, but they concluded that the most likely source was these what they call the fecal bioaerosols through the pipes. And as I said in the presentation, they actually tested the hypothesis by putting gas in the system, and they actually detected gas, that special detectable gas, in other floors above when they put it on the pipes. And they also cultured some of the apartments that were empty, and they found virus in the apartments that were empty. So that was another piece of evidence that not only they showed that the testing gas could move up, but also they demonstrated presence of virus in one of the floors above the 15th floor. That was an apartment that there had been no humans there because of it was empty. So that was another piece of evidence that probably it actually traveled somehow. And what they said is that these families, the difference between this family and other families is that they didn't use the bathtub. So the hypothesis was that the manhole, the thing that is like a U, was not with the water seal. It was actually dry. So the gas or the bioaerosols can actually travel backward and go through the drain, as opposed to people who are using their showers or their bathtubs, and they were filled with water in the U part. So all of those were like sort of circumstantial evidence, but the conclusion was that most likely was through this type of pipes in the building, as opposed to some other way.
Great, thank you. Fascinating. The other about in terms of the bus outbreak, a couple of questions asked about masks. Were people wearing masks?
No, they were not. They were not wearing masks. It was really early in the epidemic, and what the author says is that in that city there hadn't been any cases of COVID-19 at that moment, so people were not really wearing masks. And as I said, they shared the bus, and they also were together in the temple, and they had, I think, either lunch or dinner during the activity. But the interesting thing was the contagion occurred mainly in the bus. There were a few cases among other participants that didn't share the bus, but it was definitely the bus, the area where most of the positive. And the other interesting thing is that those who were in the bus did not sit together to have lunch. They actually were mixed with other groups. So it was definitely the contact during the bus trip more than the contact in the temple. Although there were, as I said, I think 9 or 7 who got infected outside the bus, presumably, and all of those who got infected outside the bus had direct contact with the index case in the bus during the ceremony, etc.
Great, thank you. And Lynn Colmar asked, maybe Lynn, you must have read this study, but she said riders sitting by open windows did not get infected, however. Is that correct?
That I don't know. I know they have the drawings of the windows in the bus, but I don't remember that detail, to be honest.
I don't know, Lynn, if you can unmute yourself, and did you?
Yeah, thank you so much. All those presentations were so fantastic. Thank you all. Yeah, I thought that study was really fascinating, that even the symptomatic patient wasn't coughing. He had no symptoms until later. His whole family was then infected, but nobody in the other bus, and each bus had, almost 70 people. So I don't, it's concerning, but I'm trying to think of what we can learn from that, because especially with all the fires, now we have to be more inside. So your advice is appreciated.
Mm-hmm.
Yeah, thank you, Lynn. Nestor, did you have something else?
I think, one is try to avoid any crowded areas. Buses, restaurants, places that are closed. And if you cannot, obviously wear a mask. And the other thing is to try to improve the ventilation. And it was the same with the example of the restaurant in China. If you have a closed area, if there's any way you can open a couple of windows, to have air circulation, air exchange. Obviously, there are ways to produce air exchange with special, air conditioning system and machines and HEPA filter. But if you can't, at least have a ventilator area. That's what I'm telling my colleagues in Latin America, to try to instruct people who own restaurants or small businesses to have their doors open, especially in tropical climates where you can have the door opens and windows open. So there's at least some air circulation within those closed places, and obviously wear the mask for the variolization too.
Thank you, Nestor. And Marla, there's a couple of questions, you may have seen them in the chat, just about for the vaccine, or homeless populations in congregate settings going to be prioritized as well? And also a question about domestic violence shelters.
Yeah, those other sorts of congregate living settings might be prioritized in more of the tier 2. You know, CDC and HHS will really be setting the priorities for tier 1. And then as more vaccine becomes available, states will have more ability to influence and identify priority populations on their own. So those are all settings that we're already talking about, people who live in, you know, any sort of congregate living situation, people who are incarcerated, people who are in different types of shelters. You know, also for New Mexico, we have to think about our American Indian and Alaska Native population, as they've been disproportionately impacted, and should that be a priority population for vaccines? So it's part of what the working group is talking about, but initially we won't be setting the priorities at the state level. They'll be coming from the federal level, but sort of as vaccine availability ramps up in kind of that phase 2, we'll be able to identify some of our own priorities, and those are all areas that we're talking about.
Thank you very much. I wanted just to go to a question for Cecilia. Cecilia, can you Cecilia, thank you, Cecilia. Can you unmute yourself and introduce yourself from TriCore?
Yeah, my name is Cecilia Thompson. I recently moved here to New Mexico, and I will be working with Dr. Carissa Colbreth as Medical Director of Infectious Disease here at.
Great, thank you. We're really happy to have you. There was a question from our colleague in Española, Kim Joy, asking if we could get an update on the rapid tests for COVID, how available they are, how good they are, just any new knowledge that you have about that.
Sure. There's not a lot to update. They are not widely available at this time, and it's kind of questionable when they will become widely available. As far as the accuracy, if you look at the EUA and the product information, they do tend to make very high claims that they have, they're very good, but as they move into the general public and laboratories are able to test them with real patient samples, we've seen kind of a wide range of how well they perform. So especially now for the Binax that was made some headlines a few weeks ago, that is not widely available, and it has not been tested in clinical laboratories to verify the claims made of how accurate it is.
Great, thank you. This comes up almost every Monday, so we'll be happy to hear an update every Monday about that.
Sure.
I wanted just to go to Deborah Van Willigen from El Prado, New Mexico. I don't know if Deborah, if you can unmute yourself, but just had questions about this. I know Leslie talked a little bit about long haulers, but just whether or not there were studies that they could enroll in to sort of look at the impact of post-COVID. Deborah, are you?
Yes, I am. Can you hear me?
Yeah.
Okay, great. So I'm a family medicine doc in Taos, New Mexico, and I have two patients. One has brain fog and the other one has extreme fatigue, and they were ill in March. One of them tried to get tested and wasn't able to because she hadn't traveled, but it all, you know, they had suspicious symptoms. And so the question is, are there any studies that I can refer them to, or any further information on long haulers as it becomes more known?
Thank you, Deborah. Nestor, did you have any?
Yeah, no, I don't have any knowledge of any study here at UNM. I will have to talk to Dr. Parada. I think Deborah is here also from the group of the 1209 clinic. I mean, we are interested. We've been following. I've been exchanging some of the publications with the group of the ambulatory internal medicine. But it's something relatively new, and I'm not aware of any open enrolling studies. I can tell you there have been important publication. I was going to share it in the next week and the next Monday, but I can give you sort of an advance. There's a publication in the Lancet, if I remember correctly, about the brain or neurologic manifestations of long COVID. They use some sophisticated imaging techniques and also surveys. And there's definitely, if I remember correctly, like around 55% of the patients in that study had some neurological symptoms and a lot of findings in the imaging. There have also been cardiac manifestation in athletes. There was a publication on 26 college athletes who had some evidence of cardiac disease. So we are getting more and more information on the manifestation, not only on the subjective, reported symptoms, which are many. There's actually a large survey, like a crowdsourcing survey from University of Indiana, in which people using an app are telling their symptoms. But there's also a lot of publications on more details on the pathophysiological findings on these subjects. But not that I don't think we are doing a study now. I know Yale University will start a study, more than anything, looking at the immunological alterations. We don't know if it's low-grade virus replication, if it's those pieces of RNA that we are detecting in the nasopharyngeal testing, if they are stimulating the immune system, or it's just a hyperactive immune system and not really any virus around. We don't know what the explanation for these unusual persistent symptoms are.
Thank you.
Great. Thank you so much for the great questions. I'm the Joanna Katzman here. I'm going to take over some of the questioning now. Question from Mary Zeitner says, do we have any information about people avoiding medical care secondary to financial reasons? I need to see if you've seen that, Nestor, or perhaps Leslie Hayes has.
Leslie Hayes, Family Medicine. Oh, sorry, go ahead. I have definitely seen patients avoiding medical care because of financial stress, and it's been very hard to get people in for some testing, especially because of it. I have not seen any studies, but I gotta believe that's the case.
Nestor, what is your thinking about that?
No, I haven't. I mean, I'm a subspecialist, so I don't do primary care. But I can tell you from what I have read, I remember, I think we presented this study on cancer, how the cancer incidence went down for several cancers. Is people are not searching for the usual, I don't know if it's for financial reason or for fear of the virus, but the results is the same. People are delaying the diagnosis and their attendance to their clinics because of these epidemics. So it's something really, worrisome, because they're going to present later in the course of their diseases, many or with already established consequence or sequelae.
Thank you both. Joanna here again. Wanted to ask you a question. This is actually from Leslie, Leslie Hayes. She says, I've seen suggestions using inhaled steroids in outpatient. And is there any evidence for this? Do you know about that, Nestor?
No, I haven't reviewed the literature on that specifically. I remember seeing some planned studies in clinicaltrials.gov, but I haven't seen any published, large trial of inhaled steroids.
Great. Thank you. Another question is related to Deborah Von Willigen, who was just on the phone, asked this question about masks and might carbon or other filter masks be helpful if used as inserts? And have you seen anything about that, Nestor?
No, I mean, the studies that we have reviewed before, there is obviously a difference between the different masks. I mean, the best to filter everything are the N95. Then probably next to that is a surgical mask, the professional grade surgical mask, then the procedure mask, and then you have the whole plethora of other, cotton with polyester mask, regular mask, all the way down to the lowest, which is bandanas, that I remember in one of the studies had the least filtering capacity. So there's sort of a very diverse variety of masks with diverse abilities to filter. And there was a paper on this that actually tried to evaluate the retention of particles with different materials. I remember that. And obviously N95 and surgical mask got the number 1 and 2 place in quality.
Thank you, Nestor. I'm wondering if Dan might be able to come on if he might be able to unmute and ask his questions about the apps related to contact tracing. Perhaps Marla might have any,
Sure.
be able to answer that. Thanks, Dan.
Hi. Hi, thank you all for your efforts in this. I was just, the test, trace, and isolate is the public health response for that involves contact tracing, and Apple and Google released these Bluetooth enabled apps that supposedly have anonymity built into them in a real integral way. And I was wondering if they've been studied at all, and if there's, you know, the protocols for test, trace, and isolate has been a big challenge for public health departments, I think. And I was wondering if there's been any quality improvement efforts in that, or like if there's protocols for that are becoming best practices. And lastly, about that, you know, is it still a viable strategy? Are there just too many, you know, is the horse out of the barn? Are there just too many infections to be able to effectively test, trace, and isolate, you know, track down the contact? Is that realistic anymore? So
Thanks, Dan. Yeah, great. Marla, might you be able to speak to Dan's question?
Sure. So I think there was a good article in Nature talking about the Google and Apple contact tracing apps. And there wasn't any sort of outcome or efficacy data, but they did talk about implementation challenges. Uptake for this kind of tracing in the United States has not been good. People are, you know, have not been motivated or interested in participating in these kind of location sharing and data sharing apps for contact tracing. So the uptake in the United States has been really challenging. So they've not really been rolled out in a wide usage the way I think you know, we thought there was promise maybe for them. There's not been much uptake in the US, but there's a good article in Nature about that that you can read. It's really interesting. And I think in terms of contact tracing, you know, now in New Mexico, where our case counts are much lower, we actually, you know, have an opportunity for contact tracing to be more effective again. To your point, when there's widespread community transmission, it's harder to pinpoint, you know, what the exposures or the contacts might have been. But now that, you know, our case counts are much lower, our test positivity rate is much lower, our R effective is below 1, we really do have the opportunity to identify those transmission events and small clusters and use contact tracing to try to isolate people and prevent further spread. So we definitely went through a phase where contact tracing was probably less effective, but because we've brought the case counts down significantly, contact tracing can be more effective than it was when we were sort of, you know, at the height of community transmission.
Thanks, Marla. We're really grateful to how well New Mexico is doing, and it's primarily because of everything you're doing. Doug Clark has a question for us, and as you know, Doug works for the state, and he says, is there any evidence regarding COVID risks and obtaining dental care? Do you know about that, Nestor?
No, I just remember either hearing or in a podcast or something that the risk is low, that there hasn't been many cases, but I honestly have not reviewed the literature in depth to give an opinion. I don't know if somebody else can.
I don't know for sure, but I do know World Health Organization about a month ago recommended against routine dental care right now. So.
Great. This is Joanne. I did want to just mention that Jane Epstein put a very nice comment in the chat about the lasting misery of coronavirus long haulers, and she also put in the website to the article in Nature. So thanks for that, Jane. I'm going to go to one more question and then have Carla follow up after me. And the dental care settings, okay.
Joanna, if you want, I can ask a question to Marla.
Please. Yes, please.
I have been following the numbers of the Department of Health, and I see that there were a couple of days that were 30s and 60s and 40s, and then all of a sudden jumped to 160. I don't remember exactly the number. Is there some type of periodicity? Can you comment on that? How? I mean, because for me, as a infectious disease, it doesn't make sense to go so up and down unless there's a human factor, like reports get on Monday and Wednesday, and not every day is the same. So can you comment on that?
Right, yeah, so those case reports that come out each day that are in the press release and updated on our website are test results from that day. So they don't correspond to the date the test was collected. You do see that in our 7-day rolling average. And so trying to sort of smooth out those peaks and valleys. But when there's a big, community-wide testing event, or those kinds of ramped up test efforts that are happening around the state, then we might get a bolus of results that all come in on one day from a particular lab, which, sort of helps account for that up and down. We also have, less timely reporting from some out-of-state reference labs. And so sometimes, again, we'll get a bolus of test results from those laboratories that can span several weeks worth of testing. And so they're not always, the results coming in aren't always related in time to when the test was collected. So that's why we use test collection date in that 7-day rolling average and in the reproductive rate calculation to try to account for those differences and smooth out those daily ups and downs.
Great.
Thank you, Marla. Back to you, Carla.
Thank you very much. I wanted to actually go back to Cecilia Thompson at TriCore. One of the questions that came in the pre-registration was about how quickly the testing, people are getting their test results back. And I know you don't know the answer for all of but in terms of TriCore, what is the turnaround time for COVID tests at this point?
It kind of depends a little bit on who's being tested. For patients that are having, that are getting a test pre-procedure, as a screening measure to determine how much PPE needs to be worn. Those have a general turnaround of 3 days, but in experience, from my experience at least, and I've only been at TriCore a few weeks now, they're resulted before that 72-hour window. All the other testing, again, in my kind of limited experience here at TriCore, has been give or take about 24 hours.
Great, thank you so much.
Mm-hmm.
Marla, I don't know if you have anything to add to that in terms of how fast you guys are getting turned around for when you're doing investigations. If you can comment on that, and also can you comment on whether there's a recommendation for testing asymptomatic individuals who've been exposed from?
Yes, so despite the confusing information that CDC released about people who've been exposed, not necessarily needing to be tested, it still is our recommendation from the Department of Health that contacts of known cases and people with known exposures be tested regardless of symptoms. So that recommendation from the Department of Health hasn't changed. I know it's been more difficult for asymptomatic people to be tested through some of the hospital-led testing events. They've kind of shifted their focus to more symptomatic testing or testing for, pre-procedure and other reasons. But asymptomatic testing for anyone is available at all of the public health offices throughout the state.
And Marla, what is the turnaround time for those tests?
Yeah, so turnaround time at the state lab is really good right now. I've seen tests come back, in as few as about 12 hours. Depending, what time of day the specimen arrives at the lab. If it makes it into the morning batch, they can turn around pretty quickly. But 24 to 36 hours at the state lab seems to be about typical right now. And that's from the time the specimen arrives at the lab. So I know there's always a lot of variability in testing that's done. The lab is in Albuquerque. Sometimes transit can be a day or more depending where the specimen is coming from. So you have to factor that in. But once it reaches the lab, right now the state lab is able to turn around pretty quickly.
Great, thank you.
And it's interesting because I have a family member who is quite symptomatic awaiting COVID test results, and she's currently over 96 hours and hasn't gotten the results yet through, I believe, Prez is sending them to TriCore. So there are definitely delays some places.
Yeah, correct. And I know, I don't want to speak for TriCore, but I know that there, continue to be problems with laboratory supplies, reagents, and other lab supplies that have impacted turnaround time, at different laboratories.
Thank you very much. I just wanted to remind everybody that the CME link just went into the chat about 12:45. So if you're interested in getting CME, please go ahead and fill that out. And also, even if you don't want CME, we would love to hear from you. So if you would fill that out, that would be great. There's a very interesting question that was sent through the pre-registration from Deborah McCreath from Ohio, asking, why does anyone think that an effective vaccine can be created in 9 months when it usually takes much longer than that to actually create and test a vaccine? So maybe, Nestor, maybe you can approach that one.
Yeah, I'm going to get into trouble with this answer, but yeah, I mean, things have moved really fast with the COVID-19. That's, I never seen that. I worked in vaccine research in my country for many years, and yes, it takes forever. We still don't have an effective vaccine for malaria or for HIV or for herpes. There are many diseases that are very prevalent, and we don't have a commercially available vaccine. They're still on the research, and these diseases have been known for many years. So it's true, the premise of the question, it's absolutely true. But I think everything is different with COVID-19. I mean, people are really putting a lot of money and effort in developing a vaccine. And right now, there are like between 8 and 9 vaccines that are starting human trials, phase 3 human trials. They've already gone through phase 1 and 2. And there are more than, I lost count, but the last time I saw 132 that were on human, already starting human testing in phase 1, 2. So there's a lot of work, a lot of studies going on. Regarding the phase 3 studies, I am a little bit hesitant to believe that we're going to have an available vaccine by October or by the end of October. Most of the scientists that I follow, like on social media or podcasts, etc., they have their questions, because if you imagine, if you're enrolling in a phase 3 study now, and it's a 2-dose vaccine, I mean, if you put the first dose in September, you're going to put the second dose probably in the middle of October, and then you have to wait for some time for events to occur to those who have received the placebo. So unless the vaccinated person is in the middle of a very active community outbreak, they may not have time to catch COVID-19 enough to be enough numbers to make up a statistically significant difference between them, the placebo group, and the vaccine group. So it's hard to imagine, and some of the critiques that have been voiced by the scientific community is that we don't know what's going to be considered a successful and effective or safe vaccine, because the stopping rules are not very clear. So there's a lot of questioning going back and forth. We'll just have to wait. I heard I think it was the Pfizer CEO saying that, yeah, that they're going to have some information by the end of October. So who knows? And there's so many things in discussion right now, or that it's somewhat controversial, but we have to see. But I'm kind of, I'm not sure we're going to have an answer by the end of October, but maybe I'm wrong, and we are, depending on what criteria they use for efficacy and safety with all these vaccines that are moving at really, really, really fast speed.
Great, thank you very much. And then I think we have one last question. Is there any updated information on the theory of possible reinfection or secondary infection for those who've had it previously? Dr. Seibold was asking that question.
Right. No, I haven't seen anything. I saw the paper by the group in Hong Kong who actually published the study of that person, and then the comments on the Reno, Nevada patient. But I haven't seen anything else. There was a nice review paper on the path for immunity. It's called the Path to Immunity. I think it's. I don't remember if it's the Lancet or I think it was Lancet that I really recommend for people to read about how. We understand now about immunity to this virus, because it's related to this aspect of reinfection. But I haven't seen any new really headlines on reinfection after those 2 cases that I mentioned, the Reno case and the Hong Kong case.
Great, thank you, Dr. Sosa. So thank you everyone for joining. It's really, really happy, and thank you so much to our subject matter experts. It's really excellent session today. Just a couple of announcements before we leave. Again, if you'd like CME, please go to the link in the chat. And if you were unable to get your question in today, please come back next week and we'll try to answer it at that point. There's a critical care tele-echo session on Thursday. It's now the first and third I believe. Anyway, it's 2 times a month, whatever this upcoming Thursday is. The session is about hospital testing and reinfection, and Dr. Megan Brett is going to give a talk during that echo, so that should be good. It's from 8 to 9 on Thursday morning. And if you want additional information, please go to the website and you can see what other echoes are available for you to join that are related to COVID-19. And with that, I think we will close the session, and thank you everyone for joining. We'll see you in a week.
Carla, if I could make a brief request. This is Leslie Hayes. What I'd really love to make a presentation on is a protocol for what we're going to do with all the snot-nosed little kids this winter, if we're going to be testing every time the toddler gets a fever and runny nose, which with my kids would have meant I was testing them twice a month. And I cannot find a protocol anywhere. So if anyone finds a protocol, if you would send it to me, I would be very grateful, because I'd love to present something on that, because I'm actually not quite sure how to approach that. So
yeah, absolutely. Let us know, or if Marla, if you have, maybe Marla's thought about this, but maybe we could talk about it next week. Thank you, everyone.